Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to everyone who has joined us on this rather hot Saturday morning for this webinar on navigating health literacy needs for older adults in healthcare, a topic which undoubtedly is a great challenge in paving the way for healthy aging. This webinar is being recorded and will be uploaded later to our YouTube channel as a resource material. Ladies and gentlemen, it's important that we equip aging adults with the health literacy tools they need to take care of themselves better, especially during the ongoing COVID-19 crisis, where we cannot afford to leave anyone behind, and no one is safe until everyone is safe. Health literacy has been identified as one of the most pressing healthcare challenges. The National Health Mobility Survey has reported, and it has been cited repeatedly, that in general, 35.1% of Malaysian adults have low health literacy. Almost a third of them have low health literacy in managing medical issues, a third with low health literacy related with disease prevention, and a third with low health literacy in health promotion and healthy lifestyle practices. With the increasing prevalence of non-communicable diseases, or NCDs, amongst Malaysians, it's important that we recognize the growing numbers of older people with NCDs and multi-morbidity as a challenge to aged care. The risk of cognitive impairment and dementia further compounds this concern. Malaysia is quickly moving towards an aging population. We know this, yet for some reason, Malaysia has been considered to be unprepared for the challenges of such a development. It is expected by 2040 that the elderly population will make up 14.5% of the population. As such, it is vital that the adults are able to transition into old age equipped with good health, proper care, and knowledge to better tend to their health concerns and need. That being said, older adults aged 16 and above are in fact a special population of healthcare users, and that puts doctors, pharmacists, and other health professionals at a very interesting position. It presents a unique opportunity which we cannot afford to neglect. Healthcare professionals in their line of duty interact with older adults who often have at least one medical condition. They take medications and bear age-related problems that can hinder communication and understanding. Being at the front lines of care and management, health professionals play an important role in promoting health literacy and addressing the concerns of our aged folk. Today, amidst the COVID-19 public health emergency, older people have been identified as a vulnerable group needing to be shielded and, most importantly, vaccinated as quickly as possible. The UK data has clearly indicated the benefits of prioritizing this group of people, which has resulted in much lower mortality. However, it does require more effective interaction and communication to ensure that they are aware and not exclude themselves from the vaccination program. So this is why we're here today, really, to discuss how healthcare professionals can effectively interact with older adults. We're going to explore some of the ways to involve older adults in managing their health and medication, and how to communicate better with them in the clinical setting. We believe that engaging each other in clinical consultations helps to foster positive patient-practitioner relationships, and ideally partnerships where the patient is informed and empowered enough to participate in discussions about their own health, and by extension, better able to live healthily. So in addition to our distinguished speakers, who I'll introduce shortly, our participants at this webinar today are from various sectors of the health fraternity, which include doctors, pharmacists, graduates, and even students. So it's a diverse representation, which is a testimony to the commitment in promoting good health and well-being through health literacy. So, ladies and gentlemen, that's enough from me. I'm sure we're all eager enough to want to hear what we have to learn from our speakers. So let me introduce the first of our two distinguished speakers. who are here with us today. Professor Dr. Tan Mo Pin, who is a very familiar name and face in this area of geriatric medicine, is a professor in the field at the University of Malaya's Faculty of Medicine. Prof. Dr. Tan is also an established researcher studying the aged population, and she leads in the Aging and Regenerative Medicine Research Trust and the Aging and Age Associated Disorders Research Group. It's a very long name there, Prof. Tan. Today, she will be speaking to us about communicating with older patients. Basic skills almost. So, Professor, let's hear how we can better communicate with our older patients. Over to you, Prof.
Mute myself and let's share my slides. Okay, yeah, right. Thank you very much for the opportunity to talk about communication. Yeah, I don't often ask to talk about communication, but actually communication is what the geriatrician does with the older patient. So actually it's a skill that is not measured very well, but really it's surprising what a little bit of communication does when it comes to looking after older patients. So like George Bernard Shaw says, the single biggest problem with communication is the illusion that it has taken place. So a lot of times as healthcare professionals, we've spoken to our patients, we think, but have they actually taken in anything of what we've actually told them? So, but life becomes more challenging because when it comes to older people, because there are existing societal perceptions, there are also issues with lots of heterogeneity and also lots of differences in ability. So, by that I refer to ethnic differences. So, you know, our older people are all different compared to each other. No two older person is the same. And that's what makes being a geriatrician so interesting, because you will never get bored doing this job, because even right until time comes for your retirement, you still meet someone that you still see something that you've never seen before. They are all different and they are all very, very special. But they are not so different compared to us, because we are also all different, but just perhaps not as different as them. And perhaps we are also we also belong to lots of ethnic groups, and we also have lots of different abilities. But the difference perhaps is that the variation we tend to see in adults is not as big as the variation we see in older adults. So often when I teach my students, I spend a lot of time making them understand this. So maybe we stop here, okay? I'd like to and have a pause here and have a little think. Okay, I'd like to ask you, when was the last time you actually spoke to someone age 60 and over? If you have a little think, okay? Think about that moment when you last spoke to someone 60 years and over. It could have been yesterday. It could have been your own parent. It could have been that market stall holder you actually went, if any one of you went to the market this morning. Could have been the person you bought your breakfast from. Yeah. If you imagine the interaction, what was it like?
Slow.
Hello? Yeah.
A bit slow in response.
Yeah, slow. Yes, that's right. Okay, sometimes. Yeah, okay. Did you have to, you know, speak particularly differently from when you actually spoke to a person over the age, under the age of 60? Did you behave differently? Did you have a different perception of them before you even started speaking to them? I think part of the fundamental thing is that we think that older people are different. But for me, I just think of them as one of us. That we should never discriminate people according to their age. And in fact, one of the things that we are fighting for in this current COVID pandemic is the fact that a lot of healthcare decisions, whether you're entitled to intensive care, an artificial ventilator, whether you're entitled to being able to have the best and most effective treatment, are decided basically by just what age you are, your number. And so internationally, a lot of healthcare systems have been challenged by this, and there have now been increasingly complex mechanisms and also ever-shifting ways by which we are now making these important life-changing decisions. So, but when you think about the older patient, you must remember that most of them do not have dementia. Most of them speak a language you can understand. And most of them can make decisions for themselves. Most of them can hear you. And most of them can see you. I know it sounds strange that I have to remind people of this, but this is what happens when in my practice, I have to remind people to speak to the patient, because it's become such a mental barrier that communication in older people is difficult. Doctors and a lot of healthcare professionals avoid it altogether. They automatically look for their children and make the beeline for their children and start talking to them. Sometimes they just make the beeline for the person next to the patient who looks younger, and talk to them without even asking whether they actually are their adult children or a relative at all. So when it comes to communicating to older people, we have to speak to them. I know it sounds like a really weird concept, but yes, speak to the patient. And this is what we've consistently failed to do. But but when you speak to the patient, you have to think a bit more about why and how you're going to actually approach the patient. You need to think a bit more about the purpose of the consultation and what you want to achieve out of that consultation. But first and foremost, you have to understand that this is the patient still has a right to privacy. So when a person reaches 18, they actually get an IC, but according to the law, nobody else makes decision for them. They are no longer a dependent. And that nobody then can actually, they are responsible for the decision and nobody can actually make a decision for them. But by the fact that they are over 18, they are also protected by the Data Protection Act. So you must remember that by not speaking to the patient about the patient without the patient's permission, you are actually in violation of the Data Protection Act. So you need to know that the patient will have a right to sue you for actually revealing personal information. There is a law protecting our patients that is consistently being ignored. And so I plead to you today, when you next see an older patient as a healthcare professional, please remember that you must first respect the patient's right to privacy. But more than that, I mean, we always think you should know that the law is the lowest level of ethics. Healthcare professionals are actually guided by good medical practices, and we must always maintain patients' confidentiality, and we must always maintain patients' dignity at all times. And that really is part of good medical practice. Yeah, I spent a little bit of time on this slide speaking to the patient. But what I hope that people, if you leave this talk with nothing else, you will remember that next time you speak to an older patient, you will actually ask everyone else next to the patient to leave the room first and verify that the patient is actually happy for somebody else to be in the same room as them when you have that private conversation. Medical conversations can be very intimate, and by having somebody else in the room and asking somebody else about the patient, you lose a lot of information, vital information, but most of all, you have violated the person's right to confidentiality. When you reach 60, you do not lose your right to confidentiality. So I will move on, because we will hopefully end on a high note, okay? So don't forget that. So why is it that people think that it is difficult to communicate with the older adult? Well, their beliefs are perhaps a little bit different. It doesn't mean they're wrong. They're just different from what we think, what we believe. Healthcare professionals, doctors particularly, have a disease that makes them think they're always right, and that they actually, whatever they believe to be true is absolutely true. And unfortunately, we never once consider that the older person has had a wealth of experiences, and we might have so much more to learn from them, and that whatever they know might be more true than what we know, and there is no right or wrong. So the older person has health beliefs, and it will be fallacy to believe that whatever their belief is untrue, and not what we believe and just because it's not the same as our belief. But it does make it difficult when we don't believe the same things. So I'll expand on this in a little bit. The older person is also afraid of the doctor. And we have only ourselves to blame. Imagine that older person now as a child. When they were little, why would they go and see a doctor? They would go to the doctor for an injection. They would go to a doctor when they fall down and cut themselves. And the doctor perhaps didn't tell them they were going to have an injection. And all they recall from that medical consultation was the pain of that injection, the ridicule by the family because they cried from that injection. Or when they fell and hurt the knee, the doctor sewed them up without any anesthetic. And so a lot of them have a fear of the doctor. And the doctor is somewhat somebody to be avoided at all costs, unless you're absolutely very sick. Sometimes there are language barriers, and whose fault is that? I am quite blessed in that I had the ability to learn more than one Chinese dialect, but it's still not enough. And I'm constantly reminded how bad my Hokkien is. I'm ethnic Hokkien. I'm sorry, my dialect is Hokkien. And my children now only speaks Chinese, Mandarin Chinese. They don't speak any other dialect. And I have to say that I do spend a lot more trouble learning. I did spend a lot more trouble learning Mandarin Chinese, English, and Malay, the 3 languages, than my children do, because they are very happy that they can communicate in one language. Unfortunately, they've chosen English as that language. And because as long as they can communicate in English, they can get by. So we've lost a lot of languages in our culture, and that has made it very difficult, often challenging, because we do not speak the same native languages. But those are actually not disease-related factors. They're cultural-related factors that often influence why the older person can appear to be a challenge when we communicate with them. Older persons can also have medical issues that might make communication more difficult. They might have speech difficulties. They might be a bit forgetful. They might be hard of hearing. They might have problem with the vision. And they might get also a bit tired because, I suppose, they've had lots of medical problems. All the energy has now been spent, and perhaps they are nearing the end of their lives, and they get tired easily. So let's talk about the unconvinced patient. Most of the time when I ask my students, why is it difficult? Why do you find it difficult to talk to your older patient? They don't want to talk to us. They don't want to be in hospital. They don't want to tell me what's wrong with them. They don't want to tell the doctor what's wrong with them because they never wanted to be there in the first place. Someone brought them there forcibly without their permission. It is very difficult. And so a lot more needs to be invested in winning the trust of that older person. But you also need to respect the patient's wishes not to be there. And if that is the case, and they adamantly affirm that they do not want to be there, as a healthcare professional, perhaps we should respect their wishes and facilitate a discharge. But if we do feel that a discharge is unsafe, for instance, a patient's ability to make decision is in question, or more commonly, the family will not let you, then perhaps it is, or the patient would be willing to stay after all, then you'll have to invest the time in trying to actually win this person over. It might take more than one encounter, but usually, most of the time there is a, well, I suppose for a geriatrician, it's a magic formula. Yeah. So breaking the ice is very important. And this gets easier and faster the more older people you see. So the only way of getting good at talking to an older person is to do it more often. And you will find what older people like talking about. But as a general rule, getting to know them is important. Respecting them for their status in society is extremely important. Find out what they used to do before they retired. In fact, some of them would still be working. Some of them would still be actively contributing to the economy, and some of them holds very important decisions. So without recognizing that the person in front of you is someone to be respected, you're not going to win this battle. Next, listen to them. We always say, ask the open question. What can I do for you today? Stop and listen. And don't interrupt. They will stop, trust me. And usually the patient stops in less than 1 minute. It takes time to earn their trusts. And so sometimes the first 3, 4, 5 minutes of the conversation is not about why they're in hospital, but about rather mundane things to you and me, but something very important to them as to what they used to do, talking about politics, what's happening to our current country, talking about their hometown, their favorite food, and also finding out the underlying agenda, why they are really here. I'm here because my son brought me. I'm here because they made me come. It's not possible, if you only know one dominant language, to, of course, learn all the languages in a very short time, but it's easy enough to learn a few words. And those few words might eventually evolve to phrases and sentences. And so learn a few keywords to actually communicate with your patients. Avoid translations to family members, because what they tend to do is they will process the questions and sometimes refuse to translate and choose to understand, to actually respond to the question themselves. And they sometimes change the answers. You would not know any better. Consider using professional interpreters, though that's few and far between in our culture. But as we have more and more internationals in our country, hopefully that professional interpreters will become more of the norm. But the other group of professional interpreters are, of course, your own colleagues, medical colleagues, who actually speak the same language as your patient, or sometimes just a language that both them and they understand. So, for instance, someone who speaks Cantonese you might struggle to find another doctor who speaks Cantonese nowadays, but that patient might be able to speak Mandarin. But you might find a colleague who can speak Mandarin to the patient who speaks Cantonese, and then the patient answers in Cantonese and understands the Mandarin but answers in Cantonese, and that doctor who speaks Mandarin understands Cantonese. You might have to use pictures. After all, we own mobile phones, so we can always just call up a picture on the mobile phone, use gestures, and if the patient is able to read and write, Google Translate can also be of assistance. Oops. Okay, now what happens if the patient is hard of hearing? That is quite common, but as mentioned earlier, not all older people are hard of hearing. So assume they have normal hearing until they struggle to hear you, or until they tell you, I can't hear you. Otherwise, you will end up shouting at every older patient who turns up. Older people have high-frequency sensory neural deafnesses. So shouting actually makes it worse because you increase the pitch of your voice. Instead, make sure there's good lighting, make sure there's light shining on your face, and speak slowly so that they can lip read in a low tone, so to actually increase the chance of them picking up your speech and to actually avoid any embarrassment, because there's nothing worse than shouting at the top of your voice, have you opened your bowels? If they have hearing aids, help them put that on, make sure the battery is working. And nowadays, most healthcare facilities should also own a hearing amplifier for individuals whose hearing aids are not working, and also those who do not actually own a hearing aid. Speech. Older people might have had a stroke, so they have speech problems. We call this dysphagia. They might have problems with their teeth. Their false teeth is loose, or they might have pain in their mouth, or their tongue might not be working properly, either because of a stroke, or sometimes it's due to cancer surgery, and they have a dysarthria. They have problems articulating their speech. Sometimes they have a problem with their vocal cord, so they can't make the noise. So we call that dysphonia, but they're still able to actually speak without projecting their voice. It's still possible to communicate, but it takes time. So easy to fix problems are loose teeth. You can buy products to help them fix their teeth properly, then they can speak clearly. Sometimes it's a problem of comprehension. So if they've had a stroke, or if they've got dementia, so you can try and keep your words simple, sentences as short as possible, use gestures, pictures, and also check for understanding. Sometimes they say the wrong things. We call this jargon speech. They can't express themselves as well as they can. Again, repetition will help, but also allowing them to express themselves through gestures and also pictures rather than just words alone. And nowadays, we've got our mobile phones. There are communication aid apps that actually helps us to actually use pictures and other means of communication, include rather than just speaking. So I'm nearly done. Cognitive impairment. Most people were thinking that I would be telling them how to communicate with people with dementia whenever we give a talk on communicating in older adults. In fact, when it comes to patients in hospital, if you're over the age of 65, we have found that 1 in 4 of them will have issues with their cognition. It's not because they have dementia, but because their acute illnesses might make them a little bit more confused. However, it doesn't mean they can't communicate, and the person's ability to communicate might actually be preserved, and you should assume so until proven otherwise. So they might forget why they're here. So that perhaps is the worst thing you should start by asking. Take your history the wrong way round. Find out about what they used to do. What was their job? Where do they live? And then find out about what previous medical problems they have, because they're most likely to remember those. And find out, and then ask them about how they feel, the current symptoms. Don't ask them why they're in hospital, because they might not know. But they know how they feel at that time. They know where their pain is. They know whether they're short of breath. They know whether they're feeling tired or whether they're feeling sick. And usually they remember what medical problems they've had previously, and they rarely forget what they used to do as an occupation. But of course, you'll need to verify this information first with your medical records to avoid repetition, but also take collateral history from family members or potential informants. Sometimes this is not a family member. It might be a domestic, foreign domestic worker, or it might actually be a formal caregiver, or it might be a neighbor or a friend. So, older people do get tired, especially when they're sick. Younger people get tired when they're sick too, but older people are more likely to get tired when they're sick because they have less reserve. So it's important to give them regular breaks. It is almost impossible to complete the assessments of an older person because of the complexity in one go. And therefore, even in that consultation, offer regular breaks. Usually our students are given 1 hour to clock our patients. And that is not possible for the older person. It's not a model that is actually sustainable in a world where more and more older people are aging. More and more people are aging. And we have more than half of our patients in a hospital now are over the age of 60. So we need to really examine the way we teach our medical students and the way we carry out our exams, because otherwise students will be examined on patients who they'll not be treating. So regular breaks, and also consider breaking it into multiple short sessions, which is really what we do on a geriatric ward. And therefore, assessments can take not 30 minutes, but several weeks. But that is the way it is. As our country ages, as the world ages, that's the way that we have to practice medicine. So I'll end here because I'm getting tired, and I look forward to lots of interactive questions after Rosmaliah's talk.
Thank you, Professor. Thank you so much for that illuminating presentation. And certainly, I have so many questions that I want to ask, and I've already started seeing some questions on the chat box. And I just wanted to also remind everyone, any interested wanting to ask questions, please do submit your questions to the Q&A section of the Zoom platform. We have heard so much just now about the issue of right to privacy, which sometimes we forget that even those who are older are entitled to. The ability to be able to make independent decisions is something that I think, especially in our Asian culture, we tend to take on a role on behalf of those who are older on basically good intentions, but inevitably sometimes ends up harming them. I think the point on dignity just now is something, again, we don't hear enough about. I'm so warmed by the compassion that's been demonstrated by Prof. Tan just now. And I think the need to continue to communicate as much as possible with those who are older and to provide them with the agency to be able to speak to them, to allow them to make their own decisions and not to infantilize, basically, them in their role, even though they are in a capacity where they need care. But that doesn't mean that decisions are removed. And I think one of the most difficult things that I've heard in this presentation, and I think we'll discuss it a little bit further later on, is the ability to convince older patients on decisions that are being made, sometimes on their own behalf, but needing to still have their own ability and input into those decisions being made. I think there's so much to discuss there, and we will definitely go into that later on during the presentation. For our next speaker, we have with us a very experienced, in fact, I would even say pioneer, who is based at the hospital Kuala Lumpur. She is Rosmaliah Alias, who is an experienced clinical ward pharmacist and is actually a pioneer in geriatric pharmacotherapy in the country. She holds a master's in clinical pharmacy and has done research in the fields of geriatrics and pharmacy. She has previously contributed to the framework of healthcare services under the National Policy for Older Adults, or the Dasar Warga Emas Negara. We will be hearing from next about some pragmatic aspects or some tools that we can actually use to look at medication management to address the issue of low health literacy. So with that, I pass it on to Prof. Rosmaliah to continue on our discussion for this morning. Please go ahead, Prof.
Okay, hi everyone. Okay, can everyone see my slide?
We can see it, Puan. If you could just slideshow it, and it will go.
Okay, hold on. Yeah. All right. Okay. Thank you for the kind introduction. Basically, I'm not the first pioneer. I have so many seniors before me. Either they are in practice or in academician area. Okay, thank you so much for Galen Centre. Yes?
Excuse me, Puan. Sorry, your presentation is still not on slideshow. If you could just switch to slideshow.
Okay, hold on. Sure. Okay.
Okay.
Okay, can you see?
Yeah. Still not on slideshow. Still like this.
How about now?
Okay.
Okay. Okay, sorry. I forgot to click the screen. Okay. So thank you so much. So I will start my part. So as you all know, even though in statistics it shows that we only have about 6 to 10% nowadays our elderly patients, but they are the majority of the group who actually registered in our healthcare facilities. Okay, and the problem is that when we have more people who are aged more than 60, they are a group of people who are actually visiting our healthcare facilities more than 5 times per year. And they use the public outpatient services about more than 50%, and they are at risk of more number of admission as compared to a younger adult. And once they're admitted, they stay longer in the hospital, and they also use more public hospital, which is about 83%. So we are actually not dealing with just a simple diabetes, hypertension, or stroke patient. We are dealing with multiple comorbidities. And with multiple comorbidities, we have a lot of medication, because there's always a guideline to aid us in terms of, to improve in terms of quality of care. So this is the problem with this older population, whereby they might need help from each of us in healthcare, and also not in healthcare, in terms of how to empower the community so that they have a better management in medication. Okay, just to highlight to everyone, it's very important for you all to know that World Health Organization already reported that people with chronic illness, approximately 50% do not take their medication as prescribed. And remember, if you don't take your medication, it won't work. So here are some questions that I would like to bring up and share with everyone about how we can help them and manage these problems of medication management. Sorry. Okay, so what are some tools that pharmacists and doctors can potentially use for older adults with multiple medication regime, but having difficulty in remembering and recognizing, adhering to taking them? Okay, so first of all, I want everyone to be focused in terms of, number one, we need to make sure they have a good cognition and we know their capabilities in terms of handling medication and their understanding of their diseases. Then only you need to continue with performing medication review, so that at the end of the day, you can design a good intervention whereby you may consider to de-prescribe some of medication that may not required. You need to counsel them so that they continue understand about your medication management plan. Consider some aids to help them to adhere with your treatment, and you should continue monitoring with the management plan. So what do I mean by that? Why do we need to know about their capability and ability of taking medication? So when you give a treatment or you give a medication, it's not as simple as you just swallow the medication. It's a process whereby when you start swallowing the medication, the first part is that you prescribe the medication, and the medication is actually administered to the patient. And in this process, there are a lot of other factors actually affecting the process of administration, whereby in terms of their lifestyle, who they depend on, their mental health, their environment itself, in terms of social support, and other factors that may actually affecting and reducing the ability to adhere to the prescribed medication. And once the medication being prescribed in a process of drugs reach to the target and give the effect, you need a good cognition and good cognitive function, or if you don't have it, who are going to help you in terms of administering the medication. And once it's been administered, it will reach to the target site, then only it can give your clinical outcome. So in the process of a drug that's been swallowed and reached to the target, there are so many other factors in terms of absorption, distribution of the medication to the whole part of your body, metabolic processing the drug into active form or inactive form, and then excreted the drugs, because a drug should not remain longer in your body. It needs to go out. And once it reaches to the target site, it needs to give an effect, whereby at the site, usually there are so many other factors that are affecting the response of the drug, such as drug-drug interaction, the sensitivity of a receptor towards a drug that's been given to the patient. I take a simple example. You can see this is a graph of, a scan of a person who tried to take a medication. So this is a very old person. This is the tablet. It takes time actually to swallow the medication before it go down to the esophagus to be absorbed later. So as simple as paracetamol, it need a time to penetrate and arrive at your blood-brain barrier to block what we call a cyclooxygenase, and then it can block the prostaglandin at the central nervous system so that it able to inhibit the endogenous pyrogen. Then only it can give you your antipyretic effect about 120 minutes later. However, if at the first part of swallowing, absorption been reduced because of the aging process, so the onset of antipyretic might be affected or delayed. Okay, so that's why very important for us to determine at the first level the level of the health literacy that they have. Okay, number one, look at your patient. At what level of your patient ability and capabilities, then only you set a goal. You may deal with a very frail elderly with a mild to moderate support or very good support, or you are dealing with a very robust elderly. And on top of that, you also should not forget about a very vulnerable group, what we call as dementia protected group, whereby currently there is no cure, and as a disease progresses, the burden will increase. And the target of treatment usually more to thinking about the quality of life versus reduced mortality. And this person who live with dementia tend to rely heavily on their family caregivers to manage their medicine, which can sometimes create a burden and negativity impact of the caregiver's quality of life. So for example, in this paper, Challenges to Optimal Medicine Use in Persons Who Are Living with Dementia, they have a problem in terms of organizing and scheduling in terms of logistically. For example, to maintain a stock of medication at home, to fit the caregiver schedules, and also the patient itself regarding when managing especially a complex regime and polypharmacy. They also think that simple tasks can be very complicated and lead to distress and delay administration of medication, and also difficulties in administration because caregivers will consider modify the formulation when the patient refuses to take the medication. Apart of that, when you deal with caregiver, they might only involve as a minor role in terms of, for example, like giving anti-dementia at the beginning side, or they are also involved, they have a greater role, especially when dealing moderate to severe stage, whereby they are more anxious and it is very challenging of giving medication because the adherence might be difficult. For persons who are living with dementia at early stage, they may know when to refuse, and as a disease process, the delusion, their belief might affecting the process of administer the medication. But at late stage, usually they are more compliant, but they forgot how to swallow or how to remember to take the medication. So it is very important for you to understand the level of the health literacy. Don't forget to assess the cognition and the support that are available. Once you know that, try to make them understand about their disease. And important when the doctors or prescriber change their medication, and once they convince enough, then only they will adhere with your treatment plan. So once you're done with that part, you should not forget about performing medication review. So just take 1 minute. What do you think about medication review? What do you understand about doing medication review? Anyone? Okay, so basically medication review is just reviewing the medication list. Okay, sounds simple, but when you deal with elderly with multiple comorbidities, it takes time. It needs skills and it needs patience, and you need to have the communication skill to do this process of medication review. So as example, these are some of my patients who are dealing not only one, but more than 10 of medication with multiple follow-up in different healthcare facilities. So how do we educating among our pharmacist team or among our healthcare provider? It's very important, number one, to identify whether the patient had a polypharmacy or not. Because polypharmacy always create a, not most of the time, a negative event if it's inappropriately managed or poorly managed. Once you identify, you need to ensure everything is appropriate. Sometimes you just can't avoid of giving medication more than 5. So then proceed with, try your best to simplify the regime, but do not stop there. You need to help the elderly or the caregiver to understand about their medicine in terms of aiding their adherence process. Okay, why is it very important to identify polypharmacy? Because polypharmacy is always a cycle of process of giving treatment plan to a patient. For example, as I already mentioned earlier, when you're dealing with multiple comorbidities patient, they often end up with multiple follow-up. And when you fail to reconcile the medication as part of the medication review process, you always end up with polypharmacy, whereby you might know or you might not know. And this end up with drug-drug interaction, which subsequently lead to adverse drug reaction. And most of the time, 50% of them won't adhere to the polypharmacy, which the doctor might thought is a failure of treatment, or the symptom is a new disease, and it will lead to a prescribing cascade, and sometimes treatment fail, and the cycle keep on going if you don't reconcile at the beginning of the process. So just to share with you, in a health HKL and in most services that provide geriatric medication therapy adherence clinic, we use IMAS to evaluate patient medication profile. If you can see this part, we always never forget to assess the patient medication management at every visit, because the elderly always change their caretaker, their environment of management. So that is why you should always reassess about medication management at their home. You need to look at whether they are using any aid, their capabilities and abilities in terms of function, whether they have hearing impairment, visual impairment, cognitive problem, what are the best language they understand better, so that we can give the counseling at the language that they can communicate better. Is there any functional or physical disability that affect the process of handling the devices and medication? Is there any support or any helper that can help them? Is there any swallowing issues, even though they are not pathological, having a swallowing or dysphagia? Sometimes they just had pill dysphagia, like for example, big tablets, they can't swallow. You give them 10 tablets, which is almost similar to half plate of your meal, also can affect swallowing process, which subsequently will affect the compliance and adherence. And we never forget to each visit, we will look at the medication list. We will look at what are the medication being prescribed and whether they are taking as a prescribed, and what is their knowledge in terms of each medication, and including the caretaker, and whether they are using any complementary medicine at the same time. And we also check whether there are other follow-up, and we always refer to multiple sources in terms of taking the medication history. So look at this example. This is one of the drug listed in a patient file, but when we assess, patient actually taking more than 13 medications. And when we list down everything, we could actually identify some polypharmacy, some inappropriate medication used in this patient because of renal is affected and it was not adjusted, and some potentially inappropriate medication that might cause this patient to fall. So remember, after you have the list profile of the medication, you need to listen to your patient. Sometimes they are actually telling you an adverse drug reaction. Their symptoms actually adverse drug reaction until you can prove otherwise. So that is why it's very important to list down all the medication so that you can evaluate for the appropriateness of the medication. And this will reduce the risk of any unwanted event. So there are a lot of references that you can use and read and go through, okay, to guide you whether this drug is appropriate and is there any other safer alternative for you to prescribe for your medication. All right, apart from that, when there's a list of drugs, usually it's more complicated, and as I mentioned, sometimes it will increase the burden of caregiver or the patient to follow as prescribed. So that is why the list of best possible medication history will help you to identify and simplify the medication. And try your best to put in a picture so that family members can follow the plan. So after that, after you've already done everything, how are you going to make sure they understand what are you doing? Okay, it's very, very important to document the process of medication reconciliation, and please communicate. As what Dr. Prof Tan already mentioned, communication is very important, and use the best language that everyone can understand, especially your caregiver and your patient. Documented it and dated. Why I said dated? Because they keep coming in and out from hospital, or they change the healthcare services that they went to, and you always, when you date it, you know this is the latest one. So document the medication that been stopped, started, or any changes, and you must mention for what reason for the next subsequent healthcare they're aware about the management. So next, what you should do, okay, after you're doing that, you always proceed with counseling. There's no other way around that you can do to improve patient knowledge. You need to counsel, monitoring, and reassess again. Try your best to continue promoting education program through various know your medicine activities at your place. You can always use teleconference, especially in this pandemic COVID-19. We can't really go to the patient house, but you can always have the other mechanism to evaluate your patient. Never forget to simplify your patient medication regime. Look beyond medication. If you can do a home medication review or do a visit to your patient house, that will be the best approach, because sometimes in the clinic, after multiple intervention, you still cannot see the improvement in your patient. So you need to see whether is there something else that you're missing out that you need to intervene and evaluate back at home. As for example, so this patient actually had multiple follow-up whereby the caretaker has to take care of 2 of the family members, of the parents, and it is not easy when everyone asking to do a blood test, go to different clinic, and if this is poorly managed, they might under-treated or over-treated. So this is just a simple evaluation that we done before, back about 6-month evaluation. When we look at patient, how the patient managed at home, about 44% had adequate, and most of them had a problem with either overstocking or inadequate stocking of medication. The good thing is they still have an appropriate storage of medication, yet there are still about 4 of them has a problem of inappropriate storage of medication at home, which might affect your treatment plan. So for example, when we go to the patient house, this is what we see. This is from a same house. This very not so strong brother has to take care of his eldest brother who just recently had a stroke and a mother who are demented. Okay, so you need to think back when you are giving more than 10 medication, whether you're actually improving their quality of life or actually you are inducing more harm. So on top of that, not only to patient house, you can always arrange your staff, or you can incorporate with other healthcare such as community pharmacy, who can actually visiting to a nursing home and look at what are the problems that they are having at the care site. And never forget to look for ways to add their ability to adhere to the prescribed medication. And never, as what the Prof Tan already mentioned, no two other person is the same. So you cannot have the same intervention for everyone. It's always individualized. You need to tailor to each individual. Some patient might understand Chinese better, some patient might understand Malay better, and in the way you documented it must be in a form whereby they understand at home, not at your level. So when we talk about interventional strategies in improved adherence, there are so many strategies out there that been documented. It's either informational strategies or behavioral strategies, or you can combine both, depends on your patient. As for example, that is why it's very important to recognize whether your patient will require dose administration aid to improve their adherence, which should be as simple as symbols or pictogram, with very clear instruction, easy to understand, and when you explain, should be slow and steady. And sometimes they can only understand in a very simple method of labeling. Whatever that you have in the label, medication label, sometimes doesn't help so much. They don't really understand. You are dealing with like 90, 100 years old or 80 years old who are actually living back in 80 years ago, okay, during our war. So probably their level of understanding might be different. So that you need to understand why, how. Sometimes you need to give them, okay, you label like what I said, so that at home you can still take it as prescribed. Okay, there are some papers actually telling you whether which one is better than the other. For example, in this paper, medication compliance, adherence, and persistent current status of behavior and educational intervention to improve outcome. It says that there are a few methods of intervention. For example, I just took some special packaging and pill box. It is documented here, not statistically significant. Impact on adherence. Statistically significant means most probably not significant, but it does help in terms of remembering. However, some packaging might be so difficult to be used. For example, it can be as simple as just 2 doses per day, or you can use a very electronic device with alarm system. But you need to remember, when you deal with elderly, they are not at the same level of literacy. What if I do a reminder system? Should I remind them weekly, or should I remind them less frequently? In this paper, it says that if you do weekly, it does improve adherence in antihypertensive, but not the clinical outcome. But you know that if your patient adhere, means individually they will reach the aim of your treatment plan. 3 course in 4 months actually is improved adherence of anti-dyslipidemia and clinical outcome. So it's very heterogeneous. It depends on your what kind of intervention study. Okay, patient involvement and self-modeling, self-care model. Self-monitoring of pills, BP, medication schedule, home visit, and rewards was found to be moderately improved adherence. If self-monitoring BP and monthly home visit, there's no change. All right. What if you combine? In a smaller study, it shows an improvement, but when they do in a larger study, it shows no significant improvement in adherence.
Please wrap up, Yapan.
Okay, I'll be quick. So last but not least, what are the tips? Remember, in transition of care, there's always a risk of medication error. So always review the medication, follow what is being recommended by who, advise patient to keep a record, always available to the family members. And what we want to achieve in future, in every level of care, we have all the specialty, including the community support. And remember, small change can make a big difference. Just to show you, this is what a medication management service that available in HKL. Back in 2005, we have MTech, we have HMR, and now we have the latest one. We because of pandemic COVID, we can't see patient more frequent. So what we do a case manager for pharmacists to look at each of our patient and follow them, whether they have a discrepancy in terms of medication supply. All right, so as a wrap up, we know we have more geriatric in futures. Our aim to have them more functional in the community level. You should be able to understand the risk factor of non-adherence and evaluate for appropriateness. Try your best to provide a medication management service at your care, and never forget to communicate. That's all. Thank you.
Thank you, Puan. Sorry to have to cut you short there just now.
Yeah, it's okay, no problem.
It's been a fascinating presentation that you've made, actually, concerning some of the pragmatic challenges that are faced by people who are managing geriatric patients, and certainly some of the issues that you raised just now, especially concerning simple things like listing the medications taken by patients, like who would actually be doing that listing, especially if the patient themselves are unable to really be fully aware of what they're taking. Is it the caregivers? How do you overcome issues of illiteracy? You know, even the clear labeling that you put there just now, which is really good in your picture. But we know when we look at some of our older patients and family members, even, they don't do that kind of clear labeling as well as they should be. And even, I think one of your important messages there concerning keeping records, so basic, yet for many patients, you know, it's something that is very often neglected and is dependent sometimes on other people. And it goes back to the issue of communications again. I like when you said slow and steady in communicating with older patients, and sometimes we are not patient enough when it comes down to it. So we are very fortunate, actually. I just wanted to mention at this point that this webinar is coming under a project that is funded by WHO, in which we are looking at health literacy, NCDs, and COVID-19. And especially during this crisis, these issues of health literacy come into the fore because we're trying to address problems which fundamentally stem from the problems of low health literacy, and especially when it comes to older patients, there is a gap there in terms of trying to get them to be able to take care of themselves and to be able for them to be protected during this period. So we come to the Q&A section, and we can have some questions that have been put forward. So let me ask first of all, because we had this one come in earlier, you know, if we wanted to adopt an approach, and this comes from Kwan Shi Kyung, looking at what approach can be adopted to better manage the health literacy needs of those older adults who present with possible indications of cognitive decline, including short-term memory loss, poor attention span, and below average MMSE and SAGE test scores. And this is sometimes complicated by the situation of some older adults who are staying on their own. I think, Prof. Rosmaliah, you indicated just now a case where a person was a caregiver to an older brother who themselves may present problems. Just the caregiver may have his own problems, and the person who is taking care of have their own problems. And on top of that, you have somebody with a certain amount of dementia. So let me put this question both to yourselves, Prof. Dan and Prof. Rosmaliah. Prof. Dan, you want to give it a shot first? Go ahead.
That opens a huge can of worms. Thank you for asking that question. Basically, the awareness, not just amongst the general public, but also amongst healthcare professionals, of the relevance of cognitive issues is diabolical. We are in a pandemic right now, but I'm still fighting for cognitive assessments to be conducted on patients coming in with COVID-19. Now, do you know that 1 in 3 people with COVID-19 have cognitive impairment? Yet people can go through their entire hospital journey, get discharged, and not followed up because there's still a lack of recognition that COVID-19 is not just an acute disorder. It actually lasts far, far longer than the acute illness itself. And they are actually sent back to work without actually anyone testing their cognition. So we need a huge level of increase of awareness. People need to be aware that cognitive impairment itself is actually the single biggest determinant of your chance of recovery when they come to hospital. So all patients who ever encounter a healthcare service above the age of 60, in fact, I'd say all patients, all adult patients should have a memory screening. And we've already developed a very simple tool, and we hope that our healthcare service will embrace that urgently.
Thank you, Prof. Tan. Puan Rosmaliah, just now in your form, right, you, I think the one that you shared that you use at HKL, there is this indicative of health literacy level. There's medication and there's health literacy there. You know, I mean, how do you make that distinction, or how do you gauge that, especially when you consider, some of the problems that's been raised in this question about, cognitive decline? How do you assess that?
Okay, in terms of assessment, it never like one-man show. It's always a multidisciplinary. In our clinic, we have nurses, we have doctors, even some of my pharmacists, they have a different level of understanding. So it's very important for us to actually work together, ask the nurses or the doctors if we don't really understand, or to understand better about the patient ability and literacy level, so that we can formulate. But most of the time in clinic, it's kind of straightforward. You can just straight away ask the family members who actually help you to manage the medication. Is there anyone actually really supervised in terms of administration? Can you take as prescribed? Because for example, if we prescribe mecobalamin 500 microgram TDS, did you take as TDS 3 times a day, or you take as twice a day, or you take once a day? So if they don't take it as prescribed, so we must suspect there is some problem. Is it too complicated for them, or is there any other factor actually affecting the ability to follow whatever the management plan. So of course, it based on before this we really have a simple method of evaluation, and by times we improvise. So yeah, that's how it goes about.
Thanks, Rosmaliah. I think it does go a fair deal in terms of answering that question. I just wanted to also link that back to a question that came in the Q&A box here, which is concerning the design of our health system, because a lot of what Puan Rosmaliah has indicated there requires a certain level of understanding concerning what is being prescribed, but also how it interacts with their management of their disease. So I want to ask Prof. Tan here, does the design of our health system create barriers for the older person to access? How can we improve or do better? And this comes from a question from one of the participants of the webinar. Go ahead.
I mean, to be honest, the situation is horrifying. It spells from wanton neglect, of decades of wanton neglect. So our health system is still built for the 1950s. It deals with infectious diseases. It doesn't address the issues with chronic disease, let alone aging. Yeah, I'm sure Prof. Puan Rosmaliah agrees with that, because we are only starting to catch up with how to manage chronic disease. Cancer has been a really neglected agenda until this decade. It's ridiculous. So where we're not anywhere near dealing with older people, and the whole system is built around the person coming forward and seeking care. There's very little proactive, preventive prevention going on in this entire system. We have the building blocks, however. It's not all despair, because a very few healthcare system can boast having a healthcare facility within 5 kilometers of 70 people, 70% of the population living within 5 kilometers of a healthcare facility, and 90% living within 10 kilometers. This is something we can really build on, but it calls for political will.
Well, let me pick that point up then. And I asked Puan Rosmaliah whether you agree with what was mentioned just now by Prof. Tan, that our systems right now are arguably not fit or future-proof to take care of our aging population. And it's really something that is possibly dating back to when infectious diseases was more of a priority. You're being part of the system that you see right now. I mean, do you agree with that assessment, Puan?
So, talking about whether our system is fit or not, definitely not yet. Definitely not yet. So, yeah, even without this pandemic-19, we also feel like we are still handicapped in terms of managing the elderly patient with multiple comorbidities, especially in a very severe stage of frailty, whereby you need family support, but it was not there. And when there's no family support, we don't really have that another support system, like a good nursing home with a different level of care that we want to. Like,
so what can we do better then, Puan?
We need to speak more. I guess so. Maybe we need to show by evidence, research definitely, so that we can bring about to the higher level. Everyone have to get involved. Actually, we are very good that nowadays we have like aging society from UPM, if I'm not mistaken. They are very aggressive now, doing research. But of course, it's been overshadowed by the pandemic-19 right now. We have other things to consider of, but we cannot stop of like continue tabulate what is our current situation now, that even though with COVID-19, we still need to continue provide our services. It should not stop there. We should not stop there. We should not like stop, we are now in COVID-19. Let's focus here. No, it should not happen there. Everyone has to look back we are actually neglecting the person who are actually still need the care. Like like for example, when this pandemic COVID-19 happened, most of our patients, we need to extend the appointment date. So what happened to the patient? We don't know. We don't have any system to actually supporting them at community level. We don't know what happened to them. I have so many times encountered patient admitted again. Oh, I don't have medication. I don't know that I need to continue medication because it's MCO. So actually, we are not doing good enough. We need to work harder so that we don't forget this.
It goes back to the point of not wanting to leave anyone behind, and because our prioritization right now is very much on COVID, we seem to be leaving people behind. I think that's a key message here that you communicated very strongly, Puan, that we need to be cognizant of, that COVID-19 is a priority, definitely, but other diseases, other conditions still exist, and we need to be able to take care of the people who are living with those conditions and diseases too, and especially when we talk about the elderly. Before COVID-19, it was really in a bad state. Now, with COVID-19, even more, and people are being deprived of care. Can I just pick up a question here from Laura Ho, who's asking, and this goes to Puan Rosmaliah, how do you find a balance between wanting to treat everything that the patient has and de-prescribing and wanting to minimize the number of tablets and medications? And sometimes, this is a great question, because sometimes I see some of our older relatives taking medication. It's like one whole genggam, you know, it's like a whole fistful of medication. It's all being treated for multiple conditions at NCD. So how do we go about this balance? Go ahead, Puan.
Okay, in practice, what we do is that, as I mentioned, medication review is very important. List down all the medication, and you need to understand what are the diseases that this patient has, and then evaluate which are the medication actually taking as what being given. Sometimes you give 10, but they only taking 5, but they are walking healthier, like nothing wrong with them. So, and there are also the other way around, whereby you're giving 10, they are taking all 10s, but they had multiple fall, they had all sorts of adverse events, they looked weak, they didn't look better as before. So then we identify each of the problem, we bring it to our team. As I mentioned, never one-man show. You need team. Of course, geriatrician, by having geriatrician is the best service that you should have. I understand that we don't have enough, right, Prof time?
We have even fewer geriatric pharmacists.
Okay, and when we have that team, then only at the end we can conclude which one to maintain or de-prescribe or to optimize. So yeah, as I mentioned, you need to really evaluate the medication profile.
So when we're talking about a single patient, it doesn't translate to a single doctor, attending clinician, or pharmacist. It's actually a team. Case management involves a group of people responsible for one particular individual, and sometimes we forget that that's needed, and as much information is needed for the case management of a single patient. So sometimes that's something that we take for granted because we don't see the team, right? And sometimes people drop. We've had cases of people being overprescribed because they don't share enough of that information with the team, and they end up being prescribed the same medication because they went to a different hospital and then prescribed the same medication, but they don't tell the next hospital that they go to or clinic that they've been prescribed. So can I just ask and pick up a question here concerning communications? And this is a very interesting one. It's actually aimed at Puan Rosmaliah, but I'm going to ask Prof Tan to comment on this first, and then going back to Puan Rosmaliah. And this is about counseling geriatric patients that have stubborn and ego behavior, such as a few groups of ex-army or soldiers who need to take medication because when they were younger, they never took medication, even though they were sick, because tough, right, Rambo and all that. So there's very macho culture there. So now that they are sick, they're older, they don't want to take, and there's a certain amount of pride there. So let me ask Prof Tan first to comment, and then we go to Puan Rosmaliah. Go ahead, Prof Tan.
The first thing is to stop thinking about them as stubborn with ego. They are nation builders. They need every respect. They deserve it. They don't have to command respect. They should automatically get respect. And so we start at that point, understand their understanding of the disease, their goal, not your goal. Yeah, because our goal is always to maintain life for as long as possible. But that might not be what they want. And then we strike a deal. Yeah, so we negotiate, and the medication that they're most likely to take are the ones that they agree to take.
Right.
Afwan?
Yeah, I agree with Prof. Tan actually. If you really look at the definition of medication adherence and appropriateness of medication, it must be agreed between the prescriber or the healthcare provider and the patient. So then only it can be achieved. But talking about this group of people, such as especially veteran, I still believe that no matter what are their background, sometimes we need to make them understand about their disease and the aim. Most of the time, maybe they don't been informed that what is this disease actually like, and what is the complication, and why we need to treat it. Why you cannot, for example, why you cannot share your medication? Why should you should not adjust by yourself, or when you should adjust your medication by yourself? Okay, so most of the time you need to always continuously educate and ask them back, what do you understand? My personal experience when I deal with older person, I always ask them back, do you know what is diabetes? It's never too late to ask them back. Sometimes they thought, oh, kencing manis. Dalam air kencing ada gula. That's what they're understanding. So we can always re-educate back why I need to help you to give this medication. Right? Take your time. As what Prof. Tan mentioned, in a short session, right? So that you don't at one session you tell them everything. So not probably only 10% coming in, registered in their mind. So in short session, or maybe you need to really understand your patient and then design the intervention individually. Okay, this part must be a bit tricky because you don't have enough manpower to do it. You need the whole team. And this pandemic COVID really teach me that I cannot only depend to my team in HKL. I need to know how to communicate with my team at the community level, right? So that is why sometimes that's why I re-engineering back my service. I do a case manager. I keep a 10 name under me. I follow up. Then most of the time, 90% they actually follow the management plan. They don't have any what we call as stop in terms of getting the supply of medication. But you can see after pandemic COVID, there's one or twice, suddenly there's no record. That is the time whereby you need to plan. Okay, I need to make a call. Okay, I need to tell my nurses, please follow up what happened to this patient. All right? So sometimes it just needs to be individualized. If you don't have enough manpower, find a network, build a network. All right? We can still keep the confidentiality. You just need to tell them what to do and then feedback to you back.
Okay.
These are the things that we're still lacking, networking. All right? Even among the healthcare facilities itself, we still need to improve in terms of that communication part in between the healthcare.
It does certainly sound like we know what we need to do, but we just haven't gotten around to mobilizing the resources, getting the support. And I think just now, Prof. Tan mentioned just now, the political will necessary to commit those resources to basically improving upon the level of care that we have. So it's good that we know what the problems are, we know how to move forward, and what we need is the next step of committing the resources and people to that. We have a question which is quite important here from one of our participants, Kanasi Rajasikaran, which is concerning nursing homes and caretakers. I thought maybe, Prof. Tan, maybe you want to take this up, which is, how do we go about educating caretakers at nursing homes or caregivers at nursing homes on managing patients' medication there. And this is because, they're not just managing one person, but they're managing several individuals in those homes. And
Yes.
how do you go about doing that properly in a safe manner, in which when a person like Puan Rosmaliah is asking for patient records or medication lists, they would be able to provide? I mean, what kind of tools, what kind of advice and communications that we need to undertake education of nursing homes? And later on, I also asked Puan Rosmaliah the same. Go ahead.
Yeah, Puan Rosmaliah will have a lot more first-hand experience. But the problem with our nursing homes is that most of them are not nursing homes. Yeah, so we don't seem to be able to have the division in the care needs of our patients. So when our doctors discharge, to just say, oh, they're being discharged to a nursing home. But there are different homes provide different grades of care, and there are different levels of funding as well. So by and large, a lot of our older people are being put in homes that are registered as care centers, and they're not they're not really nursing homes. So so they do not have the requirement of actually trained nursing care. So and why so few of them are actually registered as private healthcare facilities, which allows them then to function as nursing homes, is because the Private Healthcare Facility Act is actually extremely rigorous, and people are not able to maintain the standard. So this is a really important area. So, but then by using the Care Centre Act registered care homes, we have huge issues in that the caregivers are not really have adequate training. There's a very high turnover because it's not a very glamorous profession. Nobody wants to do it. So training is a constant thing because every few months they have a change of staff, and it's really, really difficult to maintain standard. The government has already addressed this issue in actually coming up with the private we call it the Private Aged Care Facilities Act, the PAFAS. But the problem is the COVID pandemic got in the middle, and so this act has yet to be enforced, because we have not actually. Ministry of Health is supposed to come up with all the policies, but we have not seen it yet. Of course, they have got a lot more on their plate than we had expected by this point, but it was supposed to have been enforced last year.
Okay, thanks, Puan. Thanks, Prof. Can I go to Puan Rosmaliah? I can imagine if you have 15 persons that you're taking care of in a nursing home, there's 15 individual lists of medication, 15 case files. I mean, I cannot imagine. A lot of these places are informal places as well. So as Prof. Tan mentioned just now, sometimes they're not regulated in a standardized way. So what are you seeing on the ground, Puan? Go ahead.
All right. Actually, it's very important to have a trained personnel in facilities that provide healthcare, especially to the elderly, because they are more complex. They have more multimorbidities, which require more medication, that require more supervision in terms of medication administration. And of course, when multiple comorbidities, the risk of hospitalization is much higher. So that is where the risk of discrepancy and medication error is going to happen. So it's very important in terms of maintaining the information. Should not be any gap in between when there's a transition of care. Okay, that's one thing. So I have encountered some nursing home which is very good. That's why the level of care is very important to have trained nursing care, because they know what to do. And as what Prof. Tan mentioned, actually the government already noted about it. And even I work with MAKPEM, Majlis Kebajikan Masyarakat, whereby they provide a train to nursing home who are registered with a government. So it's very important for each nursing home actually being registered, so that whatever training that we can provide to the nursing home personnel can be provided. If not, we might missing out here and there. But at the same time, actually, we're aware that we need to continually educate the nursing home And there's a lot of activities ongoing actually. It's just that because of this pandemic COVID, some of them are actually like withhold. Even not only talking about nursing home, I'm talking about at the community level. We have actually so many plans before the pandemic COVID, because we know that the healthcare can't cope anymore. We need a community to help us to continually support the elderly at their level. For example, my personal experience work with Taman Desa residents, whereby they have a very good community support. I think one of the participants also attending this event, they keep on continue. They have what we call as, they keep a network with a healthcare provider. So, and they keep a record of their residents, and they have a monthly event or every 2 months event or even weekly event to continue make sure that their residents keep on healthy. And if they have problems, they know where to get help. And they are actually monitoring each other. Okay? So like whether at nursing home or a community level, it's very important to have a trained personnel.
Thank you, Puan Rosmaliah. That is really nicely answering the question that I wanted to ask, but you entered it nicely into it, which is the first question really that was asked in this whole webinar, which is what role or effort can the community, like residents associations, play to improve on health literacy, communication, support for older adults, especially in this present pandemic. And Puan, you gave it very nicely there, a key example also of how the community is able to also provide some support. So I want to give this opportunity also to Prof. Tan to add on to what you just said just now. How can the community help in providing more support, especially in terms of health literacy and communications to older adults?
The support system has already been, when the system doesn't meet the needs of the people do take things into their hands. So the support system is there. Unfortunately, it's not easy to regulate because, who they choose to believe can be very dangerous. Yeah, so they could, the community leader might actually be kind of an anti-vaxxer. They might not believe, might have health beliefs that sway way towards a lot of alternative treatment. So we do need to have systems where we can actually identify who in the community would be a really good person that people turn to. But as Rosmaliah says, there's a lot of communities locally now. They either act as residents associations, they act, or senior citizens associations, or just a lot of these schools. They have alumni, and all those actually provide support for those who have healthcare needs. So they usually find a retired nurse or a retired doctor who can actually help educate people in that direction. So yeah, we already have ongoing community initiatives that really needs to be highlighted, so that every village and every housing estate will say, oh, they have theirs, let's form ours too. Those sort of things. So that's really what we really need people to do.
Thank you very much, Prof. Tan. So we're coming to the end of the webinar. So we have just, I think, one final question that's quite important, I think, for us to answer moving forward, and especially since we want to go to where we want to be, which is the level of geriatric care that we should have. So if I may ask for both of your views concerning where do you think we should go for the next steps? Where should we, if you wanted to pick one item that you want to be able to recommend to the government today to be able to address when it comes to geriatric care, what would it be? As I think both of you mentioned, we're in COVID-19, everything's being prioritized for that. Attention span is short, resources are limited. If you had a chance to speak to our policymakers right now, what would you recommend? Just one thing and I ask both of you. If I could ask Prof. Tan first, I can see Puan Rosmaliah sitting there thinking. So Prof. Tan, go ahead first.
Untapped resources. I think we all know that the people now with extra capacity are our general practitioners. So let's give them the opportunity to obtain some training in caring for older people, and let's do some private-public partnership. They already have all these GP practices all there within the community. That we need to work with them, revisit their payment systems. Why are they not working together with the public hospitals to, as well as private hospitals, in fact, even to actually ensure seamless care in the community? It's the payment system.
Thank you, Prof. Tan, and I go to Puan Rosmaliah.
All right. Okay. For my opinion, I think most of my team opinion too, I think actually we are on the right track. We are already on the right track. We are moving towards like making sure that by 2030, we do already at least prepare that we are dealing with aging population. It's just that we need to work harder. So therefore, the government and all the stakeholders need to actively involve to provide at whatever role and capabilities they can help us to make sure that the care for elderly is at optimum level, at the best level, right? And as what Prof mentioned, if GP has the extra capabilities, same goes with pharmacists. We have community pharmacists, whereby we need to continue to train them so that we have the whole networking, whether in rural or urban, so there won't be anyone miss out. And yep, we're going to have a very good, healthy, aging country in future.
Okay, well, thank you very much, Puan Rosmaliah. Thank you very much to Prof. Tan for being great guests for the webinar this morning. And we certainly appreciate your clear and insightful opinions and perspectives concerning this very important issue. We're happy that we've been able to get you on this Saturday morning, and certainly I feel that you have raised more questions that can be answered within the short time of this webinar, and I do hope we can continue on this conversation further. As I mentioned earlier, this webinar recording will be made available on YouTube, and I do hope that those of you who are unable to participate, for your colleagues, would be able to refer to the YouTube channel later on once it's been uploaded, so that you can pick up on anything that you've left or you were unable to follow earlier. So with that, I would like to again thank Prof. Dr. Tan and Puan Rosmaliah for spending their morning, and most importantly to all of you for participating in this webinar discussing health literacy needs of older adults in healthcare. So with that, I'm Azra Makhalid from the Galen Centre for Health and Social Policy. Thank all of you for spending your time, and wishing you a best weekend, and also please do take care and stay safe. With that, thank you very much. Assalamualaikum warahmatullahi wabarakatuh, and a very good day.